So good afternoon. Royce and I are here to talk about virtual oncology care and some of the trends in the market. Specifically, we want to advance the knowledge about technologies out in the industry and what folks are using, use some case examples to talk through that from recent highlights of virtual care implementation in several of the AMCs and community cancer centers. And then last, and on how, as you look to design your own virtual cancer care center and service, how you might develop that and what you should expect as implementation moves forward. So in terms of recent advances in virtual oncology care, I'm sure that many of you are familiar with the statistics that you see here. So this was a telehealth adoption tracker that the Chartist Group used in combination with Kythera Labs. And what this showed is during the first rise in the pandemic, that there was an uptick, a great uptick of about 30% in telehealth visits for oncology care, both in hematology and radiation oncology. And then that trend has now flattened out to more of a 10 to 15% status at this time. And so, you know, a lot of times we get questioned about the percentage that you should strive for. And what we would say about that is it's more about the model of care that you want to implement, and it's less about hitting a certain percentage. And so we're going to talk about ways that conversion in other virtual care methodologies can be impactful to your program. To start our discussion, we'd like to poll you as an audience and actually see what percentage of your patients that were under active diagnosis and treatment were seen virtually at least once in the past year. So now moving into some of the technologies and virtual care adoption methodologies that we see across the country. The first of those obviously was virtual visits. And, you know, as you see on the slide, there are a continuum of ways that you can virtually engage. And so virtual visits was a mainstay at the start of the pandemic. What we've seen since then is an expansion into other arenas of digital communications, such as reporting of EPROs, tailored text, voice, and email messages to promote adherence with screenings. Moving into navigation, many navigation programs went virtual, as well as genetic counseling programs went virtual. And then probably the greatest degree of virtual care integration is that some programs have actually started chemotherapy at home programs. An example of that would be UPenn's program where they do home-based chemo. They actually, you know, these are still fairly limited to a number of regimens, maybe 10 or less. And some of those are in pilot program mode, but many are looking to adopt this, particularly considering the reimbursement of care in the home now. So looking at how virtual care is implemented, we really think about it in the stages of the cancer journey. The first stage being the screening and intake elements of the cancer care journey, by diagnosis and treatment, and then on to navigation support as the patient has care throughout that continuum. And what you find there is that different goals are met by engaging in these realms. So we have seen a good bit of adoption longitudinally to get a faster time to appointment on the screening and intake side of the equation. Whereas with diagnosis and treatment, we've seen that that's really been great engagement, a level of great engagement with cancer care teams for multi-D care review and treatment planning and clinical trial screening and enrollment even. And then finally, as the patient goes through their care journey, we've seen great expansion of clinical outreach, and remote monitoring to improve care outcomes and to increase the number of interventions that you could do virtually with the patient to make it more seamless through their care. So a second poll question that we had for you all is which of the A through E here would you find most important to your organization to implement, or maybe you have implemented, that will carry you through the next 12 months? So on to a few virtual care center highlights. And I mentioned we would have some case examples to speak through with you all as an audience. And the first of these, we're going to start with the Moffitt Cancer Center. And Moffitt is the top-rate cancer center. They have a very broad geography, actually extending across the globe. But they were finding that patients were struggling with getting appointments quickly. So a significant number of their patients had to wait 14 days for a new consultation appointment, as an example. And so the COVID, even though they were currently underway with improving these access issues, the COVID impact really accelerated their use of virtual care technologies and methodologies. And so I'll have Royce now talk through how they implemented their virtual care program, and others also followed in different ways.
Thanks, Kelly. So when we think about Moffitt's cancer care program and some of the challenges with access that Kelly had mentioned, it really took a methodical approach to thinking about what are the different points along the initial part of a patient's cancer care journey that can be impacted by the use of digital tools, whether to support the process of care or the care interaction itself. And some of the programs that they've developed really with that kind of singular goal in mind are listed here. And what you find is that in totality, these actually address a lot of the issues with access, whether it's with having the ability to actually engage with a patient, to register virtually, or to facilitate some of the components of visit pre-work that can happen through a mobile app, and also providing appointment reminders as a way to really confirm that given the kind of day-to-day changes that we've all been experiencing, that there is visibility into the appointment pipeline and being able to anticipate potential cancellations and no-shows, and making sure patients are prepared for their appointments. And then wrapping all around all that is a more dedicated patient appointment center that really had the goal of being a central point of support for the different stages of this process, that can provide facilitation of the scheduling and the financial clearance and some of the care coordination as well, as an augmentation of some of the digital means of interacting with Moffitt. One of the things that they also saw was a dramatic uptick in virtual visits, which they've been able to sustain at a relatively high level, really as a result of this kind of end-to-end thinking of what are the barriers that might prevent a patient from being able to get to the point where they've arrived at their appointment. And so as it relates to virtual visits, they really saw a dramatic, thousand-fold, increase in the number of visits during the beginning of the pandemic, and really continued to sustain somewhere on the order of 300 plus visits a day, on the order of 4,000 visits a month, as an indication of their ability to really lean into providing some of the care and support services for cancer patients at the beginning of their journey virtually. I want to move on and speak a little bit to another organization, Great Lakes Cancer Care Collaborative, which is based in Western New York and is really the cancer center for Kaleida Health, for ECMC, and many physician groups, as well as other clinical partners in that region. And one of the challenges that they faced at the beginning of the pandemic really related to the continued facilitation of their tumor boards, which were largely done in person prior to March of 2020. They in migrating to a virtual care, virtual tumor board platform, they were able to coordinate the upfront case prep and get access to medical records prior to a tumor conference. They were able to integrate some of the clinical trial recommendations in terms of matching, as well as cancer-specific clinical guidelines at the point of the case presentation to be able to facilitate a more robust discussion, and actually have the leverage the audio and video communications capabilities to have that tumor conference experience really in a virtual setting. The outcomes they've been able to see have actually been quite tremendous. They did not miss a single tumor conference throughout that initial transition to virtual. They were actually able to expand tumor board participation so that for both in terms of attendance and in terms of the reach and type of specialists and members of the multidisciplinary team that could attend went up dramatically. And they also were able to streamline information as it was being collected in case prep, so that each case that was presented, by definition, had already gone through a really rigorous process of making sure all available information, whether it's imaging and pathology and clinical records, were really prepared and ready to go to have a robust discussion. One radiologist actually, mentioned that they may never want to go back to doing in-person tumor boards again, just because of just the power and the potential and connectivity of facilitating some of these tumor boards virtually. Another example in this diagnosis and treatment domain really comes out of Utah. So the Huntsman Cancer Institute, which is the cancer institute associated with the University of Utah, serves a really broad region from Nevada to Idaho and Wyoming, and obviously Utah itself and Colorado. And they've, by serving that mountain area, have a really wide-reaching need to serve cancer patients over a broad geography. And so they developed, even before the pandemic, a Huntsman at-home program that's really focused on providing hospital-level care, whether it's completion of IV therapy or advanced symptom management, managing rehydration and post-surgical care, and making that available in the home setting. Now, they were targeting either the clinical setting in which patients were potentially eligible for early hospital discharge, or as a direct admit to hospital at home from the ED. But they also were open to clinical referrals for care teams who were seeing their patients potentially headed the way of being needing admission to an inpatient care setting, and being able to in some ways get in front of that and provide that care at home. The model of care is actually quite intensive. It involves a comprehensive team-based approach to care that includes folks that are available remotely, but also folks that are on the ground. And it includes up to having RN visits multiple times a day, as well as a daily visit from an NP or physician, and then wrapping that around with 24/7 on-call availability, as well as a bunch of devices and services to really make sure that the hospital level of care can be provided at home. Now, for this reason, they've really focused the model on specific geographies where they can have the density to serve the patients both centrally, but also in terms of the quote unquote field resources in terms of clinicians and other devices that need to be brought to and from the home setting. What they were able to see was both an impact in terms of care utilization and reducing unplanned utilization of both hospitals as well as ED visits. And more recently, this is actually as recent as the end of 2020, CMS began paying for these acute care at home programs through a demonstration project that included Huntsman and their Huntsman at Home program as one of 6 institutions, and has really been expanding to other organizations that are prepared and able to offer hospital level care at home. So this remains an area I think that in addition to what Kelly mentioned around delivering chemotherapy at home, remains an area of tremendous promise going forward. The last case I wanted to highlight is really around navigation with Levine Cancer Institute, which is part of Atrium Health and provides cancer care in 25 locations to patients throughout the Carolinas and beyond. Their new patients every year is north of 16,000, 17,000. They really actually had a robust nurse navigation program even before the pandemic. And what they were able to do at the beginning of the pandemic is really transition really rapidly to a virtual navigation model. And they provided support both inbound and outbound in terms of calls so that the nurse navigators were able to more effectively and more efficiently serve patients in a newly remote model, including being able to join by audio and video for in-person medical consultations that were still happening. Now, really, the benefit here was pretty tremendous, and it wasn't so much about proving a new source of value, but really anchored in the fact that there's increasing evidence around the importance of patient navigation for cancer programs, both clinically as well as from a business perspective. With outcomes ranging from being able to reduce the utilization of ICU stays, as well as reducing the need for unplanned readmissions, and then from more of an organizational and business perspective, being able to demonstrate that there is a increased likelihood of patients staying with the cancer program for a full course of treatment, and also being able to provide some greater level of support that leads to satisfaction for referring providers, particularly referring surgeons. And so this is a really kind of powerful example of being able to transition a model that already works in a pre-digital world, and really taking the opportunity to be able to further extend and scale that impact. So now, having provided an overview of a couple of organizations that have taken different approaches to developing virtual care capabilities, we want to really revisit this concept of a virtual care center. The goal here really is to think about how you can tie the various components that we've provided some examples of into a more comprehensive digital hub that can serve patients, caregivers, as well as the multi-D team in delivering consistent, high quality standard of care. And one of the things that we'll really focus on here is really thinking about what are the things that really fall within this virtual care center, which really isn't necessarily about being able to bring a bunch of care team members physically under a single facility, but rather providing the set of tools that can facilitate better communication across different members of the care team to do things like automated screening, providing a more robust and rapid patient intake, coordinating across navigators and registrars and schedulers, and making sure that the full team, whether it's the supportive care providers, research coordinators, are able to have visibility into a single set of care goals for every patient, and benefit from technology and being able to do so. So to dive a little bit further into the concept of virtual care center, what it entails, and also how to go about thinking of establishing or augmenting your current capabilities, we really outlined here both the stakeholders, if you look on the left, that really are impacted and the functions that they provide, whether it's service centers and support centers up at the top, or the navigation teams and the multidisciplinary care teams, as well as the network of supportive care that really comes around the patient, and thinking about what are the needs that could be provided centrally, whether it's guidelines or protocols that are augmented by knowledge management systems, or workflow tools that are really closely integrated with a medical record, so that you can provide better visibility into service interactions, into communications that enhance some of the documentation that exists just within the clinical record itself. Thinking about the communication platforms that support virtual care, as well as remote monitoring, and some of the intelligence and logic around clinical decision support that build on top of that, as well as the data infrastructure and the workforce development that really helps make sure that the information that's being used, as well as the folks that are going to be more closely coordinating through this digital modality, are prepared in a way to support effective and efficient care. Now, in thinking about how to expand upon this concept in your organization, we've provided some high-level steps more as a guideline to kind of spur your thinking. The first and foremost is this concept of really focusing on specific disease side programs and thinking about how you can really focus on meeting the needs of a specific segment of patients and the care teams that support them, with the goal of being able to really have a lot of focus in mapping out what are the services that need to be coordinated, what are the information flows, what are the workflows, and that really serves as one, a precursor to the planning work to be done, but also, a good reminder of who are the stakeholders that are most important to engage in order to be able to effectively create this virtual care, hub model. When you have gone through those first two steps, then it's, really where you start thinking about what are the actual processes and the tooling that's required. This is an opportunity to really think about the resources that are going to help support the care and what systems such as knowledge management systems that are going to be able to make, the clinical pathways and the different guidelines that, not only the care team, but some of the support teams around scheduling will want to be able to follow in a systematic way. And also thinking about what are the different data sources, whether it's the CRM, the customer relationship management system, the medical record, or even enterprise resource planning tools, particularly when you get into the hospital home type of offering that you'll need to be coordinating in order to have all the information that you need, together. And it really can be as tactical as making sure that you have master copies of data in terms of contact information that becomes so much more important when you're trying to coordinate in a digital way across this many members of the care team. And finally, once you have that universe of what are the initial things that you really need to be able to integrate and develop in place, then thinking about how do you really communicate the scope and the service available within this virtual care center, and the process by which you start to transition folks who, whether they're members of the care team that need to be trained or referring providers and clinicians that, need some support in understanding how to better interact with the services that are now being organized centrally, and thinking about how, to really make that transition, as quick as possible, but, as smooth as possible as well. Over time, this model actually, really comes alive in step 5, where you start thinking about what improvements can be made, what opportunities to expand into adjacent, services or into new disease sites, and really kind of having a model that you can build from. You'll find that as you go through this, the first one will be the hardest, and progressively you'll be able to, establish a playbook of incorporating more services and more disease side programs over time. I'll conclude with a little bit of lessons from the field. I won't go through everything that's presented on this page. What I want to highlight from just our experience is that a couple of things that we find that are coming up again and again. One is just the need for clarity around what's within scope for the virtual care center. There's a lot of services that will potentially overlap with what a virtual care center can offer. So clarity around what it does and does not do, and the timing of maybe some of these transitions you're thinking about, implementing this, are going to be very important for a broad set of stakeholders. The second thing I'll highlight is you will find that there will be an opportunity to rethink workflow. This isn't necessarily about just digitizing what is currently, a manual or an analog workflow, and really thinking about, are there different ways of working with the care team that, such as a virtual tumor board, right, that fundamentally allows, more members of the care team to participate, allows for perhaps a greater frequency, and thinking about some of the parameters of the model that, can change into a digital model. And then the last thing I'll highlight is that a lot of this is about how digital enables information flow. And you'll find that you'll have the greatest value in thinking about where there's a lot of handoffs. And so we would encourage, as you, really think about the next phase and wherever, you are in the journey for your organization, what are the opportunities to really, bring some structure to areas where there's a lot of information handoff, a lot of handoff among members of the care team, and the immediate value that'll bring in, more clarity and more, alignment around what the care goals are and what the kind of next best actions, if you will, are for the patients that you're managing, in the clinic setting. And so with that, I wanted to, really close with a couple of poll questions just to get a pulse from this group. One topic we would want to get feedback from you all is how would you describe the current state of your virtual cancer care program? When you look at the options here in terms of video visits and remote symptom management, navigation, trial screening, even hospital home, how many apply to things that you all are doing today or planning on doing? The final question, if you are just beginning this journey and have just a budding presence in virtual care today, do you plan to establish or expand virtual cancer services within a given time frame? So, we want to get your understanding of, is this something that's in development now, something that would happen in the next 3 to 6 to 9 months, or perhaps something that's in 2022 and beyond? Great. With that, thank you for your time and your engagement. We're really excited to be able to share some of this information to